Non-alcoholic fatty liver disease, commonly called NAFLD, is a high-prevalence condition driven by the epidemics of obesity and diabetes, and now affecting approximately 25% of adult population. In a non-negligible proportion of cases, let's say 5%, it may progress to non-alcoholic steatohepatitis, fibrosis, and cirrhosis, as well as to hepatocellular carcinoma. At present, there are no licensed drugs for NAFLD, and lifestyle intervention remains the only treatment accepted by international guidelines. In the presence of type 2 diabetes mellitus, novel antidiabetic drugs may offer an opportunity to reduce the risk of NASH progression by adequate control of glucose and lipid metabolism. In the paper, we discuss a decalogue to reduce the burden of NAFLD in patients with diabetes and the different results achieved by the use of novel drugs on liver disease. First of all, it is mandatory to implement a systematic, intensive, continuing lifestyle intervention, that is, healthy diet and habitual physical activity aimed at maintaining or slowly achieving a near normal body weight. Physical activity is particularly needed to prevent sarcopenia. Doctors have to carefully assess the NAFLD stage by surrogate biomarkers, as well as the presence of diabetes comorbidities, above all cardiovascular and renal impairment. In patients with cirrhosis, determine Child-Pugh class and MELD score. Then it is possible to define a treatment target based on patients' frailty and disease severity. Although glycated hemoglobin below 6.5% may be the desired target in subjects without comorbidities, in individual cases values up to 8% may be acceptable. Consider that glycated hemoglobin may be unreliable in the presence of anemia, and random glucose monitoring may be advisable. For what concerns treatment, background metformin should always be used, also in compensated cirrhosis dealing with renal function. Sulfonylureas and glycinides should not be used except as third-line therapy. They both increase the risk of hypoglycemia, and sulfonylureas are also associated with the increased cardiovascular risk. Very useful to add pioglitazone at 30 to 45 mg per day in patients not at risk of heart failure or ascites. DPP-4 inhibitors are useful to improve glucose control in patients without comorbidities, while GLP-1 receptor agonists should be preferred in patients at risk of cardiovascular disease. SGLT2 inhibitors should be preferred in patients at risk of heart failure or progressive decline of glomerular filtration rate. As long as possible, avoid insulin to reduce the risk of hypoglycemia and the impact on the quality of life. Surely insulin may be needed in the most advanced stages. Combination of basal insulin with new drugs may be an option in selected cases. In conclusion, we are living a new era in the pharmacological treatment of type 2 diabetes, and patients with NAFLD are likely to take a higher advantage from novel agents. The beneficial effects of GLP-1 receptor agonists and SGLT2 inhibitors on metabolic outcomes go beyond glycemic control to obesity, cardiovascular risk, heart failure, and renal disease, and might soon be available for NAFLD patients also without diabetes.